I'm Dr. Gary, I'm one of the registrars with at UCT. I'm going to be presenting this morning about Keratosis, Obturans, primary auditory canal cholesteatoma, and benign necrotising otitis externa, and just going through the actual conditions and how to differentiate them clinically and otherwise. So just a disclaimer, consent was obtained for any patient data that is used. There's no intent on copyright infringement and all the relevant data is referenced. Okay, throughout the presentation, I use multiple abbreviations for the various conditions: keratosis, obturans, primary auditory canal cholesteatoma, and benign necrotising otitis externa, as well as external auditory canal. These are the ones that will come up regularly. So just to start off, so there is a difference between keratosis, obturans, and acquired and auditory canal cholesteatoma. It was first defined in the 1980s. Since then, articles on keratosis, obturans before then likely contained cases that were probably primary acquired auditory canal cholesteatoma, as well as vice versa, because there wasn't a clear definition before then. So recent articles on necrotizing otitis externa and auditory canal cholesteatoma still contain cases that contain clinical and pathological overlap. Keratosis obturans is a different clinical and pathological entity from primary auditory canal cholesteatoma and benign necrotizing otitis externa. The difference between auditory canal cholesteatoma and benign necrotizing otitis externa is less clear. So keratosis obturans is the accumulation of a large plug of desquamated keratin in the external auditory meatus. The primary auditory canal cholesteatoma is an invasion of the squamous epithelium into a localized area of bone erosion, with or without bony necrosis. And benign necrotizing otitis externa is the formation of an avascular bony sequestration of the inferior tympanic bone with secondary inflammation of the overlying soft tissue and skin. In terms of the pathology associated with them, in keratosis obturans, it's a geometrically patterned keratin plug within the lumen of an expanded external auditory canal. The keratin squames shed from complete circumference of the ear canal, and in that sort of laminar arrangement, which is like an onion skinned arrangement. In primary acquired canal cholesteatoma, the keratin is derived primarily from a sac that involves the bone of the canal and the bony fragments within it, with random keratin in the lumen of the canal as well. In benign necrotizing otitis externa, the necrotic sequestration of the bone involves the superficial cortical layer primarily, and histologically shows a dead laminar bone with inflammatory cells filling the marrow spaces. So in this diagram, this diagram illustrates what I just spoke about, talking about the different types of conditions we are going through. And in the first image in A, you can see a normal ear canal. In B, it shows the benign necrotizing otitis externa with an exposed area of bone, and in C, you see a canal cholesteatoma, which has a sac, which is eroding into the bone, which has skin covering it, which is where the squamous tissue will collect. And in keratosis obturans, you can see there's a ballooned out appearance of the entire canal. In terms of bacteriology, all three conditions culture skin flora mainly, with a wide range of other bacteria. The culture bacteria include organisms such as Proteus mirabilis, Staphylococcus epidermidis, Klebsiella pneumonia, beta hemolytic streptococci, and Staphylococcus aureus is the most frequently isolated organism, and Pseudomonas is not generally found in these benign cases. In terms of etiology, keratosis obturans is due to an abnormal epithelial migration of the ear canal skin There are two types of keratosis obturans that have been described previously. One of an inflammatory nature and the second of a more silent type. The one of inflammatory nature occurs secondary to an acute problem causing inflammation of the ear canal, such as a viral infection. It temporarily alters the epithelial migration and is treated by removal. The second or silent type is a disease that persists and is caused by an abnormal separation of the keratin. This disease continues even after the first removal and will need subsequent removals regularly. In terms of auditory canal cholesteatoma, the etiology of the external auditory canal cholesteatoma is uncertain. Primary auditory canal cholesteatoma is distinguished from cholesteatoma that arises secondary to a previous ear canal insult, though. And this one usually results from a reduced migration capacity of the ear canal epithelium. It's one of the main theories. This theory, though, has been challenged by multiple studies which show that there's no difference in the epithelial migration between normal ears and those affected by the external auditory canal cholesteatoma. Benign necrotizing otitis externa is caused by a cause of a necrotic bone. It's caused by necrotic bone in the cause of the necrotic bone is largely unknown, although there are theories about the effects of the vasculature and about vascular insufficiency. The tympanic bone is particularly susceptible to osteonecrosis because of its relatively poor blood supply. And although microangiopathy of diabetes has been associated with malignant form of otitis externa, it hasn't been proven in the benign form yet. There are theories of repeated local trauma causing this, such as earbud usage or ear picking or the use of hearing aids. And this is one of the more popular theories of how this originates. In terms of clinical symptoms, the symptoms are different for keratosis obturans and acquired cholesteatoma and benign otitis externa. Keratosis obturans is more common in younger patients. It's found more common in younger patients. It classically presents with acute severe otalgia and conductive hearing loss, and it's infrequently the disease is bilateral. It's possibly associated with bronchiectasis in previous studies and sinusitis, and many of the patients in historic papers were found to have bronchiectasis and sinusitis associated. In auditory canal cholesteatoma and they have a similar set of clinical findings. The most common presentation is chronic otorrhea with a dull pain or itching. It's not normally associated with the hearing impairment. The bilateral cases account for around 1 in 6 to 12 cases, so it's more common to be bilateral as compared to keratosis obturans. And most common presenting symptoms of idiopathic external auditory canal cholesteatoma are unilateral otorrhea with mild to moderate otalgia. Just looking through some articles. There was an article done in the University of California, San Diego in 2020, looking at keratosis obturans, comparing the different pathologies of the external auditory canal. And they stated in the article that one of their findings was that keratosis obturans which was previously classified in a spectrum of external auditory canal cholesteatoma, but now is considered a separate entity characterized on imaging by circumficial soft tissue plugging and an expansion of external auditory canal without associated bone erosion, which thus distinguishes it from cholesteatoma. It's just one of the articles that supports what is described in this research. In terms of investigations, the first and primary investigation of choice is microscopic examination of the ear canal, and this is either done in the clinic or under general anesthesia if needed, and which most likely needs to be needed in certain cases such as keratosis obturans. So in keratosis obturans, the external auditory canal can become grossly widened or ballooned. In acquired in acquired canal cholesteatoma, the cholesteatoma is able to be suctioned and has fragments of bone within it. There may also be granulation tissue which requires biopsy at the time. In benign necrotizing otitis externa, the covering of the floor of the external auditory canal is dehiscent, with granulation tissue around the edges of the epithelial defect. A yellow necrotic bone in the bare area is also found with small necrotic fragments. Sorry. Okay, this is just an image that's describing the three conditions. The first one goes into keratosis obturans. Looking at a canal, you can clearly see that the canal has been widened by the disease itself. In the second image, it's an image of the section of a canal cholesteatoma, just showing a bit of squamous debris. And in the last image, it's an image of a benign necrotizing otitis externa, showing an area of denuded necrotic bone, which is visible on the floor of the nose, sorry, the floor of the external canal. In terms of investigations, the first one we'll be talking about is imaging. So in terms of imaging, the CT of a typical bones are the gold standard for imaging and the preoperative planning in external destructive diseases. This method allows an accurate evaluation of the extent of the local bone erosion, as well as to demonstrate the involvement of adjacent structures. When planning the surgery for benign necrotizing otitis externa, a CT scan may be indicated in order to identify the extent of the bony necrosis. Other investigations. At the time of presentation, a pus swab can be taken if there's a gross infection, which is obviously present. If Pseudomonas is caught, the diagnosis should be queried, more likely in favor of malignant necrotizing otitis externa. If prominent inflammatory or granulation tissue coexists, chronic granulomatous conditions such as syphilis and tuberculosis should also be excluded at the time. Other investigations include audiometry, which should be normal or show mild to conductive hearing impairment in acquired acute canal cholesteatoma and benign necrotizing externa, but can show a marked conductive hearing loss in keratosis obturans. Other investigations include a biopsy. So histologic examination of granulation tissue is required to exclude malignancies specifically, as well as other differential diagnoses, which would include other carcinoma of the canal, malignant necrotizing otitis externa, and benign neoplasms that has secondary infection in the external canal. In terms of epidemiology, the frequency of primary acquired canal cholesteatoma, auditory canal cholesteatoma, has been estimated as 1 in 1,000 new histological cases for every case of primary acquired cholesteatoma. For every primary case of canal cholesteatoma, there are 4 to 5 cases of keratosis obturans should be identified. Benign necrotizing otitis externa is probably the most common of the three conditions. In terms of the natural history and complications, there's little known of the natural history of these diseases. There are sporadic reports though, which demonstrate that normal ear canals can suddenly develop three conditions. Keratosis obturans can occur in either normal ears or in ears that have had plugs of keratin removal beforehand. Keratosis obturans can cause extensive bony erosions, including automastoidectomy. There are no reports of intracranial complications in this condition, though. In auditory canal cholesteatoma, the erosion through the anterior wall of the canal may rarely affect the tympanomandibular joint, and rarely also advanced cases can extend into the posterior cranial fossa, which result in intracranial abscess. External auditory cholesteatoma have a staging system, have two staging systems which are described. The one is by Naren et al., which is based on the proposal that there is a preclinical stage, the stage 1 and 2, which do not necessarily present to the actual hospital. They don't cause many problems, and then has further staging, which is on the picture below, which describes the different stages. So it's a stage 1 to 4, and of note in the stage 4 has subclasses depending on the extent into the jet structures. So it has letters which describe which structures are involved, such as M for mastoid and S for sigmoid sinus, and so on. The other staging system is the Singh-Ho Sin et al., which is a clinical and radiological staging system, which describes the extent of the disease. And this classification also includes treatment suggestions as with the extent of the disease that is involved. So it shows stage 1 to 4 as well. Stage 1 being limited to the external canal, and then it advances as you go down the number of numericals until it involves areas beyond the temporal bone in stage 6. So stage 4, sorry. So and then it has treatment advice on the different staging, and the diagram on the right hand side is showing the radiological view and going through the stages on how advanced the disease has progressed. Of note, there is a good diagram in Scott Brown, which basically divides all the 3 conditions, actually 4 conditions, including malignant necrotising otitis externa, and basically differentiates them in terms of the symptoms, the pathology that's involved, and it describes the treatment approaches to each one, with the differential diagnosis which can be used for each one, which are generally the conditions next to them here. So it describes everything that I've spoken about just now, but we'll go into the treatment of the different conditions right now. But we can briefly go through them here. So Keratosis, Obturans, the main treatment is to remove the plug and treat the granulations, as well as occasionally biopsy if needed, if you're concerned about other conditions being involved. Then for canal cholesteatoma, so surgically remove the cholesteatoma graft with cartilage or fascia to be placed on it, on the area of that has been dissected. And then benign necrotising otitis externa, which is treated with conservatively initially and can have surgical removal of the sequestration when required. Okay, so again, going into management. So Keratosis Obturans, like we said, the pain and the deafness associated is an indication for the removal, which is generally done under general anesthesia because of the severity of the pain. The canaloplasty has been suggested for recurrent keratosis obturans with good results in previous studies. In auditory canal cholesteatoma, conservative treatment is used where the extent of the cholesteatoma erosion can easily be seen. But if it's not able to see the exact extent, the patients are treated with excision of the necrotic bone and cholesteatoma via the mastoid, and repair of the defect using temporalis fascia generally. The only other treatment suggested is a canal procedure with repair of the defect. Management of benign necrotizing otitis externa. Conservative management consists of removing the bony sequestration once it separates spontaneously, and this can be done with local toilet or local treatment, and then local treatment can be used to control any infections. Oral antibiotics may be used as well. A more aggressive surgical approach has been advocated as well, with early surgical removal of the sequestration down to the healthy bone. Adjuvant hyperbaric oxygen has also been used, described in this literature, and there is it's advised when there is progression despite the intensive local and systemic treatment, and when there is necrosis beyond the tympanic plate. So in conclusion, just a summary of the three different conditions. So first of all, the three conditions are different diseases. Keratosis obturans generally occurs in younger patients. It presents with pain and may be associated with sinusitis as well as bronchitis. It may also be associated with disordered epithelial migration. It's either temporary or permanent, and is treated with the removal of the keratin plaque. In primary acquired canal cholesteatoma, it's more common in the elderly patients. It may be traumatic and presents with otorrhea, itching, and minimal hearing loss, and is treated with permeatal or mastoid surgery to remove the disease. In a benign necrotizing otitis externa is probably more common and has a similar clinical presentation to acquired canal cholesteatoma, but needs less radical treatment. These are my references. Thank you very much.
Yeah, and thanks so much for the very comprehensive presentation. So just a few points. The keratosis obturans that I've seen, I'm not sure if any of your texts you looked at that, but most of the patients that I've seen actually have a very stenosed lateral stenosis, and I often wonder if that's not the primary cause, and that doesn't affect the migration, which is why it makes them be exposed. I don't know. I'm just saying the ones that I've seen, and I've usually found that there usually is that ballooning once where the bone is narrowed laterally. If you do a canaloplasty for that and a meatoplasty, it usually sorts them out. I never see them again after. Yeah, it migrates well. I don't know if you came across that in any of the
describe it.
Yeah, but I've seen all of the patients, classically, they have very, very stenosed lateral meatal stenosis. So the cartilage in the skin is narrow. And if you fix that, then you sort out the problem. You can have keratosis obturans and canal cholesteatoma occurring together. I've seen that as well. And I think the reason is you get the keratin plug, and that causes trapped skin, which creates a cholesteatoma. So that can occur together. I don't always CT scan keratosis obturans because when you clean them in the clinic, once it's taken out all that, and so usually what I do is if it's very painful, which it often is, I inject some local in the clinic so that I can get everything out. And if I can see the entire ear canal, I don't do a scan. I mean, what's the scan going to tell me? I can see the entire ear canal. I know it's ballooned. The tympanic membrane is normal. The rest of the ear canal is normal. You just do the meatoplasty and the canaloplasty for that. So I think scanning would be a waste there. The only time I would scan is if you had quite an extensive canal cholesteatoma, where you suspected erosion into the mastoid, then you would, because that's going to affect how you plan your surgery.
Yeah, which is what has been described.
Yeah, so then I would scan. And then the benign necrotizing otitis externa, even though you've said it's more common, it's the one we rarely see. And I think we rarely see it because they get better on their own. Yeah. If you're needing the aggressive treatment that you've described in your presentation, I would no longer call it benign. I've never had to send someone with denuded bone for hyperbaric oxygen because of continued pain and ongoing otorrhea. That's no longer benign. That's now become a malignant otitis externa, or you have to exclude some other cause. So in my mind, benign necrotizing otitis externa is just an area of denuded bone, otherwise normal skin. What the primary insult is, I don't know. I've often asked patients whether they frequently use cotton buds, and they often do. But I've never seen benign necrotizing otitis externa coming back with ongoing otorrhea or even itching or even pain. The minute they complain of pain, I get worried.
Yeah.
So yeah, I mean, I think that's all I have to add. Obviously, malignant necrotizing otitis externa, you've got a patient with ear pain, severe tubular, and granulation tissue that you need to biopsy. So those are quite different entities, and you really actually get them confused.
Yeah.
And sometimes when you've got the keratosis, Obturans and the Cholesteatoma occurring together, then it becomes confusing. But keratosis, Obturans is very characteristic. It literally, as you take it out, it comes out in layers. Yeah. But they can have severe pain. I think they get severe pain because of the associated infection, otitis externa.
Hyperbaric oxygen, I think this is one of the issues where it's easy to get something into the literature, but difficult to get out.
Yeah.
And hyperbaric oxygen was used for all kinds of things in the past, ocular necrosis, etc., but it's really fallen by the wayside. Do you use it in Belgium?
Yes, in units.
Yeah, but you use it for your bony problems.
Not really.
Yeah, because there were, there was a big enthusiasm in the States that published widely about these ocular necrosis, etc., but they couldn't repeat the results elsewhere in the world, and so the machine was put up all over the world. Here in Cape Town, they're treating all sorts of things, but they've shut them mostly down because they just don't think it makes a difference. So I don't know whether it has got a role here, but I'm just saying it might have been described in the past without good evidence, and but I'm not sure that it is. That's not what you're saying.
Yeah, the same. I don't see just practically I've not seen any patients.
So we do put this talk up, I would take it up. Because I don't think the evidence. Yeah, I just speak. Yeah.
I don't know much to add. I just thought maybe to ask actually some practical aspects for patients with keratosis, Obturans. Anything topical you think helps kind of ease the process, and it's often you could spend an hour trying to suction all that stuff out, and then anything you get them to apply kind of the patients who are awaiting surgery or managing conservative.
So I do try and get as much out when they come to the clinic, because I think part of their pain is that superadded infection. So I infiltrate with locum, and then they actually tolerate it quite well. And then I put some Polyderm in the ear canal, and that makes a huge difference. By the time they come back, if you need to stage it because there's too much, by the time they come back the second time with that bit of Polyderm in the ear, they're actually pain is much less.
Seen many of these?
See, keratosis, Obturans now they get in the clinic.
I think my experience here has been when it's extended, which we regularly see now with long stay in hospital, and I think most of us now have management. But in terms of the benign necrotizing otitis extend, like you said, I have very little experience seeing them.
Because we don't see them, because I think they just get better on their own. And the thing about benign necrotizing otitis externa is that skin around that area is completely normal. And so I don't treat them. And if they complain of a bit of, itching and it's itching and not pain that they complain of, I treat them topically and I follow them up. But you'll find out with time that skin actually just epithelializes. So I don't treat them at all. I don't even try and remove that area of their bone. It's generally very small. And when you've got large areas of necrosis, then you're almost thinking of, and then I'd be very wary of just calling it a benign necrotising otitis externa. And then I obviously would want to scan these patients. But generally the area is so small, and patients are only complain of pain or there's tenderness when you actually go and do microscopy and you try and suction around it. But generally, they don't come in complaining of pain, it's generally itching. And that skin almost always really epithelializes. So I don't treat them at all. I follow them up and put some Polyderm in the air, follow them up, and it almost always closes. I've not seen them coming back with this constant needing to be cleaned and constant recurrent infections.
And also, a kind of different condition is ocular necrosis.
Yeah.
People have, especially patients who've had radiation for treatment. If you get this exposed bone, the anti-inflammatory ring, which is dead bone, and those also, I mean, I would manage them so but those that do pick out the dead bits of bone in the clinic, and then once the bone is gone, it just heals. And then the raw space.
Yeah, absolutely.
Yeah, because it's not what you described, but it's also unit bone. So in the first radiotherapy setting, probably lands on top of different.
Yeah,
Yeah, because they don't-
exactly.
Yeah, because they don't heal over the dead bones.
It has been described separately. There's actually a whole chapter. It's called bone just on
I'm sure.
the.
Well, thank you very much. It will be nice.
Are there any questions from the floor? Nothing, okay. So that concludes our meeting for today. Our next meeting will be on Friday. And
Then the final
Friday's a holiday. My apologies. The next meeting will be on Monday. Thank you. Have a good day. Bye.
on this very still.
Next Friday is 6.